Good evening. Hi, I'm just going to announce that we're going to start about 5 minutes late. Apparently the traffic's bad and there's been delays on the subway, so we're just going to give a few more minutes for people, to give people a chance to arrive. Okay? Thanks. Yeah, it's here. How do I go forward? Good evening, all. Hope you've had a chance to enjoy your boxed dinner, and we're going to get started now. So first of all, thank you all for coming, and a wonderful thanks to Maria Morales for organizing this. This was fantastic organization, apparent from the moment we walked in here. Just a few housekeeping issues. You have been given a white sheet, which is a question sheet for the Ask the Experts session at the end of this particular meeting. So at any time you can write out your questions and hand them to anybody with a badge on, a CSA or Spark badge. And the orange sheet is the evaluation form, and horrible things will happen to you if you don't actually fill that out as you leave. It's like one of those, spam emails. So yeah, fill out the evaluation sheet. It really helps us in making the best of these forums for you in the future. This event is being videotaped, and the videotape will be available on the Spondylitis Association's website, as well as Spark's website and the Arthritis Society website in about a month from now. If you have any questions as we go through the evening, please go to the microphone on the floor there, so that people can hear what's going on. Coat check is available and will be available afterwards at 8:30. If you've lost your number, the fine is $2, so make sure you keep that. The door closes by the second cup when accessing the hospital. If you need to access the hospital, you have to go through the main entrance door of the Kremble Discovery Tower and walk through the streets to get back into the hospital premises. The main doors of this building close promptly at 9 o'clock, so we'll have to get out by then. And if you've been eating in here, please just make sure you take all your garbage and stuff out and put it in the bins, and that will leave the place tidy. And if you need the washroom, outside to your left. And if you need to stand up at any time, obviously do it, we understand. Okay, so I'm just going to say thank you to our sponsors. These are the sponsors of the Canadian Spondylitis Association. So a big thanks to Janssen, AbbVie and Amgen for sponsoring us and allowing us to put on these forums across the country. I'm going to ask my usual question about how many people here have never been in a room with other spondylitis patients before? Hands up. Yeah, quite a few. Well, welcome to the club, and I'm sorry you have to be a member. But at any rate, this is a quote from C.S. Lewis: "Friendship is born at that moment when one person says to another, 'What, you too? I thought I was the only one.'" And I'm sure quite a few of you felt that at some point in your journey to diagnosis or treatment. Okay, I'm very quickly going to go through what the Canadian Spondylitis Association has done in the past year. And I want to do this because I feel that we've come a long way in the last year or two, and that we are a pretty integral part of the arthritis community now, which means that we're better able to serve you. Sorry, can everybody hear me? Okay, good, thanks. So in December of 2014, our new developed website went live, and if you haven't had a look at it, please take a minute to do that. I'd like to thank our medical advisors, in particular Dr. Nigel Haroon, for reviewing the content of that website. In January, we did letters of support and patient input for the SPORE network applications. These are very large government grants that are going in. So we did one for a research project called Impact MSK, and that came in number 4 out of 32 applications in the first round. And we did one for Go Mobile with Clear, which came 20th out of 32 applications and did not proceed to the next round. But the Impact MSK SPORE one, our doctors here this evening are involved in that, and it promises to be a very interesting project, and I believe it will be a successful one. There's only 4 grants going to be given out for these SPORE network grant applications. We also promoted a WebEx or webinar on biologics, your treatment, your choice. And the purpose of this actually was to inform people about SEBs. Anybody know what SEBs are? Every person in this room should know today what a SEB is, a subsequent entry biologic or biosimilar. The introduction of these SEBs in Canada has very serious ramifications for us as patients, particularly if you're on a biologic at the moment. Just to tell you how bad it can be, in Quebec, everybody on Remicade was told all of a sudden that they had to go on to a subsequent entry biologic called Inflectra because it was cheaper. And anyway, very fortunately, because of the advocacy of patient organizations and others in the healthcare professions, Quebec reversed its stance. But now we have wind that BC is trying to do the same thing. We've been to Queen's Park to talk with the Minister of Health here. We don't want to see the introduction of SEBs without a lot of consultation and consideration for the patients. So I really encourage you to learn about SEBs. If you've never heard of them before, educate yourself. This actual webcast is on our website, so you can go there and see it. In February, we attended the Canadian Rheumatology Association, and we also presented to the PSA, Psoriatic Arthritis Patient Advisory Board, about the Canadian Spondylitis Association. Most of you are probably familiar with the term spondyloarthritis. It's a group of diseases of which ankylosing spondylitis is one. Axial spondyloarthritis is sort of the early stages of AS, perhaps, is another. Psoriatic arthritis is another. Reactive arthritis is yet another spondyloarthritis disease. We haven't paid a lot of attention to PSA in the past, but certainly we want to encourage more involvement by PSA patients in our association going forward. In March, I'm a representative on the Patient Advisory Committee of the Ontario Best Practices Research Initiative, which so far has been researching the long-term effects of RA and treatments for RA, for rheumatoid arthritis, but it is now going to do the same with SPA patients. And coming up relatively soon, we'll be broadcasting advertising for patients to become involved in this long-term study. We've also done submissions of patient evidence to the Ontario, Public Drug Plan, and this was for one of the new biologics indicated for AS and PSA. And we've done already submissions to CADTHA, the Canadian Agency for Drug and, Drug and Therapy, whatever it is, it's one of those government things. Yeah. Oh, I say there, Canadian Agency for Drugs and Technology in Health. Okay, so we've done submissions there on the template for inputting patients' information and on the two of the new biologics, subsequent entry biologics. In April, we went bilingual with the French website, which was very much appreciated by our colleagues in Quebec, because funnily enough, there's really not a lot of information out there about ankylosing spondylitis in French. I also went to the annual conference of PARE, which is the Patients Against Rheumatism in Europe, which was very interesting. It's nice to be part of the global community, and we shared our best practices, and I'm pleased to say that the CSA really has good best practices compared with a lot of patient organizations around the world. In May, we had a Montreal SPA Patient Forum that was bilingual with simultaneous translation. We also participated in the World Autoimmune Arthritis Day online event. Has anybody heard of that or participated? It's a virtual conference on autoimmune arthritis, and it comes up, when is it? I think it's going to be sometime in May this year, but it's the third time we've participated. And it's interesting because you have a virtual kiosk and you get visitors from all over the world coming to it. We also participated in Walk Your Ass Off. And anybody been on my teams in the past? What? Okay. Oh, there we go. Is that Gordy over there? Yeah, thank you, Gordy. Walk Your Ass Off. Follow our website for that. It's a walking and awareness challenge. As you all know, exercise is incredibly important to us, and walking is one of the easiest and best forms of exercise. So get involved next time. You just walk at your own pace whenever you want for a month leading up to, or join the month of May this year. It used to be leading up to World Ankylosing Spondylitis Day, but it's now, I think, just in the month of May. In June, we were invited by the Arthritis Society Quebec division to look after the SPA portion of their annual congresses, their patient congresses. They've just had one in Quebec City with 850 people attending. So in the future, the next one is going to be in Montreal. They're shooting for 1,000 attendees. And Dr. It says Michael Zuma, it should say Michel Zuma of Spark in Quebec, and ourselves are going to be responsible for providing the SPA educational content at those congresses going forward, which is a big win-win for us. In July, well, it was kind of a quiet month in some ways, but fundraising is always going on. And in the past, we've had financial support from some of our pharmaceutical industry partners listed there. We also started into conversations with a company called Health Storylines, and I'll come to that later. In August, we were invited to participate in another SPORE network application, the chronic pain one, which obviously has quite a lot of bearing on what we feel. Our membership reached 1,500 people. We're growing by about 2 to 3 a week, and my goal is to get that to exceed 3,000 within the next year or so. We also started using a new Twitter handle, @SpondylitisCA, so you can follow us there. You can start tweeting about this forum if you like right now. In September, we had patient forums in conjunction with Spark and the Arthritis Society in Calgary and Saskatoon. In October, on October the 22nd, we launched the AS app. So if you haven't seen that on our website, you can see it on our website. You can download it from the Apple Store or the Google Play Store, but it is a health app for people with AS, so you can track your medications, your doctor's appointments, your moods, your fitness, etc., etc. I also attended the Arthritis Alliance of Canada's 3rd annual conference in Kananaskis, Alberta in October. I think it's important for us to be there. I did not think this one was particularly interesting for us because it's to do with OA, osteoarthritis, rather than inflammatory arthritis, but actually it was really, really interesting, and osteoarthritis is a huge challenge. I just say here that in the conference last year in Toronto, we had Sir Mark Feldman and Dr. Ravinder Maini. Those are the 2 doctors from Oxford, England, who discovered anti-TNF therapy. So any of you who are on a biologic, Remicade, Enbrel, Simponi, Humira, etc., you have to thank these doctors for that treatment option. So into the future, today we have our patient forum in Toronto with Dr. Robinman and Dr. Nigel Haroon. I'll introduce them in a minute. I don't have a lot of introduction for them, but I just have to say that we're really honored to have them here. They are world-leading experts and researchers on ankylosing spondylitis, and it is just such a privilege to have them here to speak to us. In 2016, we're probably going to try and do some webinars instead of physical forums like this, and that's really for the benefit of people in remote communities. We're actually going to try and do a forum It's coming together now in Haida Gwaii. I don't know if you know this, but the Haida peoples of the West Coast have an incredibly high prevalence of HLA-B27. Funnily enough, the incidence of AS, as I understand it, Rob, you can correct me on this if I'm wrong, but the incidence isn't actually higher than the Western European population, really. Yeah, so it's strange. They've got this propensity towards it, but it doesn't always manifest itself. Our mission is to reduce the time from onset of disease to diagnosis, and hence our awareness plans for the next year or two. You probably know that it takes 7 to 8 years on average to diagnose. Many of you have waited longer than that. Anybody here waited longer than 10 years for diagnosis? Yeah, more than 5 years? Okay, less than 5 years. Boy, you're the lucky ones, despite having been diagnosed. Okay, so that's pretty well a review of the Canadian Spondylitis Association. I would ask that you join us. It's good for you to be part of the community. In fact, when we look at the recommendations for the management of ankylosing spondylitis, you see on the left-hand side, education, exercise, physical therapy, rehabilitation, patient associations, and self-help groups. So that's what we offer, patient associations and self-help groups. And it's important, I think, to assisting you in managing your disease. And it's important to me that when I go and advocate for you in front of government, that I can say that we have, so many hundreds of members. It bears a lot of weight in numbers in front of the government. So that's my presentation. I don't think I introduced myself. I'm Michael Mallinson, President of the Canadian Spondylitis Association. It gives me great pleasure to turn this podium over to Dr. Rob Inman, who's the Director of the Spondylitis Clinic here at the Toronto Western Hospital, and Dr. Nigel Haroon, who's the co-director of the Spondylitis Clinic. They're going to talk about the current concepts on the causes of AS and an update on the medical treatment of AS. Thank you.
Thank you, Michael. I'm going to welcome to the clinic. As Michael's comments indicate, this is very much a partnership between the physicians, our research team, who's also here, but at the end of the day, the most important people in the room are the patients, you guys. So what we hope this evening to be is a dialogue, and you'll be interesting to know we learn as much from you as you learn from us. Thank you very much, Michael. I'm going to introduce Nigel Haroon now, who's going to put the context of ankylosing spondylitis in the biological framework, what we understand about it. But before I do that, I'm happy to announce, we just got an email about an hour ago. Once a year, the Canadian Rheumatology Association selects one researcher from all across Canada, all the young rheumatology researchers across Canada. And an hour ago, we found out that this year's Young Investigator Award from the Canadian Rheumatology Association is being awarded to Dr. Haroon. So it's great. Great for him, it's great for us, and it's great, wonderful profile for spondylitis, because that's what his research is all about. Ninja.
Thank you. Thanks very much, Rob, for that kind introduction. CAC has been doing tremendous work, and thanks, Michael, and your group for organizing the evening. So, let's see if I can get, okay. So the next 15 minutes or so, I'll try to cover a little bit on the pathogenesis of ankylosing spondylitis, so how it develops, what are the genes involved, what progress we've achieved over the last several years, and also maybe 2, 3, 4 slides on comorbidities which are important in patients with ankylosing spondylitis. Okay. So studies into genetic involvement of diseases can be done at multiple levels. One of the most common and earliest ways to diagnose genetic diseases is looking at twins. Another way would be to look at families. This is easy because twins and family members have shared genes, so you can control for a lot of the background genes and look for only the genes which are abnormally present in patients or affected members of families or the affected twins. So it's an easy way to do it. But the problem is we don't have numbers. We don't have a lot of twins to study. We don't have a lot of family members with multiple affected members. So another way to do it is to look at patients, a large group of patients, and then compare the genes to controls, healthy controls who don't develop disease, and see what is different between the two groups. Okay, and you can do this in two different ways. Traditionally, we have approached this in a hypothesis-driven. In other words, you have a hypothesis that this particular gene or this particular region of the chromosome may be abnormal. A good example would be TNF receptor. We know that TNF is a molecule which is important in mediating inflammation in a lot of diseases. So maybe the TNF gene is abnormal in AS, so you study specifically the TNF gene. So that's a hypothesis-driven approach. But the problem with that is you can only test so many hypotheses at one time, and you will need many decades to go through your different hypotheses. So in the last 5 to 10 years or so, the non-hypothesis-driven approaches have significantly improved our ability to study genes in diseases. So in a single slide, a chip which you've probably seen a lot of slides in your undergrad days. In that single slide, you can probably test up to 30,000 or 50,000 different genetic markers. So it has really revolutionized our ability to study genetics of diseases. And AS definitely has benefited from this advance, as you will see. This is just to show you the amount of heritability involved in AS. The first table on the top, you can see it's a comparison of concordance rates among twins. First you have monozygotic pairs, and then you have dizygotic pairs. The concordance in monozygotic pairs is around 50%. In dizygotic pairs, it's around 20%. So which means monozygotic pairs have greater gene sharing, so they're identical twins. So if you have greater gene sharing, there is a higher chance of having the second twin affected, which means that genes maybe have a role in the disease. Compared to dizygotic pairs, there is less gene sharing, so less chance of the disease developing in the second twin. Okay? And in the table below, I'll just direct your attention to the recurrence risk. So that gives you a rough number of what the recurrence risk is. And on the top, you have the different degree of relationships. So the first there is monozygotic twins. Roughly a 63% chance that the second twin will develop if they are monozygotic. When it comes to siblings, so siblings and parent-child as well as other first degree, they are almost in the same ballpark. Around 8 to 10%. That is a rough recurrence risk of having it in another member of the family, either another member who is a first degree relative. When it comes down to second degree and third degree relative, the chance of recurrence really drops down to almost population levels. So again, showing that genes are important in the development of ankylosing spondylitis. So this was the first study. You can see the date there, 1973. HLA-B27 was first identified as a strong association in AS. In fact, there's a funny story about this. So AS was more or less, sort of ignored condition, because if you have AS, it doesn't make a big difference. You just manage it like any other pain. Just take anti-inflammatory and you go. There was no other method of treatment or no advantage of making an early diagnosis in those days. And the researchers were more interested in identifying more sort of inflammatory conditions where there is evidence of a lot of inflammation, and gout is an example. So they were studying the genetics of gout, and they wanted a control population, and they thought, okay, let's take AS. It doesn't seem to have any significant genetic involvement, and this study was a result of that. When they looked at the MHC association, which is an important region for immunity, they found that 96% of AS patients had HLA-B27. There was no association with gout, so they turned out to be the controls instead of AS. So 96% of AS patients have HLA-B27. If you look at different cohorts, for example, in our cohort here, we have close to 1,000, 1,300 patients. Our prevalence is around 80%. So 80 to 90% of AS patients have HLA-B27 compared to 6 to 7%, which is the prevalence of B27 in Canada. So there's a huge increase in AS patients. So B27 has something to do with it. Since 1973, people have tried to identify what that particular mechanism is by which B27 contributes to disease. Still, we don't know why B27 is important and how it contributes. We still don't know. But just to give you an introduction to B27 and a possible mechanism by which it is causing disease, I'll just have a cartoon here. So let's imagine for a minute that you have a pink virus infection, okay? And your army really to fight that is a T cell. You can see that T cell on its helmet. But if the virus keeps running around, it's so difficult for the T cell to really attack the virus and kill it. So the body has a mechanism by which it will keep the virus under check and present it to the T cell. So this mechanism is through antigen presenting cells. Okay, so they present antigens for the body's immune system to attack it. So now the virus is taken up into this antigen presenting cell, and the particles from the virus are broken down, and it is presented on a plate on the surface of this antigen presenting cell. You can see that. Okay, and now it's easy for the T cell. It comes and just kills the cell along with the virus, and you get rid of the virus. So this particular hand on which the virus is presented, it's an MHC molecule, and your HLA-B27 is an example of such a molecule. So B27 essentially is an arm presenting the infectious organisms to your immune system so that it gets rid of it. So now if you just concentrate on this part of the immune system, that is called an immunological synapse, or it's a major junction where all the immune interactions happen. And it's possible that that particular junction may be abnormal because of B27, and that leads to an abnormal immune reaction in ankylosing spondylitis. So that is one of the most popular hypotheses. We have tried looking at, a lot of investigators from across the world have tried looking at that small particle there between the two parts of the immune system. Nobody has really been able to identify a specific peptide or a specific part of a virus or even a specific autoimmune sort of protein which may be driving this abnormal immune response. So that's really been the roadblock so far. Okay, so but if you introduce HLA-B27, just by introducing this HLA-B27 into a rat, you can see here, this is the normal paw, and you can see arthritis developing by introducing B27. You don't need to make any other change. This is the normal nail. You can see the psoriatic nail changes in the rat. Skin, psoriatic skin lesions, and the gut, a lot of inflammation in the gut compared to the normal gut. So B27 clearly is important, but how it is causing the disease is really not known. So if you look at the epidemiology around B27, and Michael alluded to it with regards to the Haida population, they have a very high prevalence of HLA-B27. So compared to the general Canadian prevalence of around 7%, I think every other person there is almost close to 50% is the prevalence of B27 in that population. So if you look at AS patients, so if you take 100 AS patients, so 90 of those 100 AS patients will have B27. Or if you flip it around, if you take 100 B27 positive individuals, only 2% have AS. So clearly 98% of B27 carriers don't develop the disease. So B27 is essential, but it's not sufficient. You probably need other players. It may be the environment, it may be multiple other genes. And we think it must be other genes because of all the story that I showed you about the twins and the family members. So with the non-hypothesis driven or genome-wide approach, so you look at the entire collection of genes in the body, now approximately 40 different regions of our chromosomes have been identified to be somewhat linked to ankylosing spondylitis. You'll see there the big tower in the middle there. So that's B27. And if you put all the other effects of all the other 39 loci from across the different chromosome, it still doesn't match the effect of B27. So all the other effects are very, very small effects, and B27 only is really the major gene. And if you put them together, still we have not been able to identify proper gene-gene interactions or any other mechanism by which AS develops. Okay, so moving on to, so that was inflammation. The next major part of pathogenesis of AS is new bone formation. And we know that both are important, but the big question is inflammation driving new bone formation? So there is no direct link between inflammation and new bone formation, but there are different methods of investigations which suggest that there might be a link between inflammation and new bone formation. So if you control inflammation with treatment, it could be anti-inflammatories, it could be TNF inhibitors, probably we can prevent spinal fusion from happening. This is just to give you an example of how a normal sacroiliac joint or SI joint, as it's popularly known as. So that's the normal this part of the spine is called the sacrum, and this is the ilium or the hip bone, and that junction there, that's the sacroiliac joint. That's the right, and this is the left sacroiliac joint. You can see clearly the joint cavity from top to bottom, and the margins of the bone are very clean, and there is no evidence of any erosions or anything. So that's a normal SI joint, and this is an example of an inflamed and destroyed SI joint. You can see that. You can hardly see the joint line. You can still make out maybe there's a little bit of joint cavity there, but more or less both joints are badly eroded and affected. So that's sacroiliitis. And along with that, another important aspect, as I mentioned, is the spinal fusion. And this is an example of a patient who has progressed over a period of 4 years from minor fusion here. You can see this part was not fused before, and it got fused over several years. The same happens in the neck. It can fuse over years, and that's spinal fusion. So inflammation is one part. The other part is spinal fusion. Now this is just to show you what the prevalence of spinal fusion is among patients. So it's just from our cohort. On the x-axis, you see 100%. If you take, say, 500 patients from our cohort, and on the y-axis, you will see the change in spinal progression. I've not put anything there. It's not like the King story, right? I'm going to put it now. Okay. So if you look at, you'll see that almost 55% of AS patients have no significant progression over a 4 to 5 year follow-up period. But if you look at the other end, around 20% have rapid progression or significant progression. So our goal really should be to identify some markers by which we can predict who is likely to progress. And if we are able to identify this group of 20% of patients who is progressing rapidly, maybe we'll be able to intervene early and at much more aggressively so that we can prevent this progression. So one of the major factors is inflammation. So inflammation appears to drive spinal fusion. And this is just to give you an example from an MRI of the spine. You can see here at that particular level where here, there is a white spot here in the corner of this vertebral body and another white spot here. So that indicates inflammation in the spine. And you can see here, just a level below that, there is no white and there is no inflammation there. And if you follow that over years, you'll see that where there was inflammation, the spine has fused. Where there was no inflammation, there is no spinal fusion. Excuse me. So maybe inflammation has some role in the spinal fusion. The second factor, which is more important, is damage. So people who already have damage when x-rays are done, at presentation, they're likely to develop more damage on follow-up. Maybe it's because they already have genes driving bone formation, or maybe it's because of a delay in diagnosing these patients. And the third, and probably the most important thing, is smoking. Smoking is probably the only environmental factor that we can really modify in ankylosing spondylitis. I'll just give you an example here. Okay, so if you look at the graph on the left, smokers versus non-smokers, smokers tend to progress at a much faster rate, and the amount of smoking is also important. 0 to 10 pack years and more than 10 pack years. So the more you smoke, the greater the likelihood of progression. So All of these factors were gathered from a multi-center study across North America. And you can see this is a matrix model to show you the predictors of progression. And you can see here damage at baseline. Thank you. So damage at baseline, inflammation, elevated CRP indicates inflammation, and smokers. And if you compare the left and right, even in those patients who don't have other predictors, just smoking itself can increase the risk of progression by more than 3 times. And with all of the other predictors of progression, smoking increases the risk of progression by almost 50% here. So smoking is really important, and if you're going to take home one message today, what can you do? Stop smoking. Yeah. Okay, so AS-related reasons to stop smoking. It's not just about spinal fusion. There is an increased risk of getting heart attacks and strokes in ankylosing spondylitis, another reason to stop smoking. And finally, there is evidence mounting that smoking can affect the efficacy of treatment, especially biologic treatment, and the smokers are more likely to fail treatment with TNF inhibitors. Okay. Apart from cardiovascular morbidity and mortality, the other important extraarticular manifestations or manifestations outside the spine are inflammation in the eye or iritis, psoriasis, so inflammation in the skin, and inflammation in the gut or inflammatory bowel disease. So three major things to look out for, and increased cardiovascular morbidity and mortality is something which you should keep in mind. I'll leave you with this graph. So it's just to show, this is from a study from across Ontario that we did. We try to look at ankylosing spondylitis patients over 15 years, so 1995 to 2010. And you can see that the number of patients has increased from around 7,000 to almost 25,000 AS patients across Ontario as of 2010, and it's increasing exponentially. Okay, none of the research is possible without the help of the funding agencies. I know that several members here are quite active in fundraising and helping us. A lot of thanks very much, and also thank you once again to the Canadian Spondylitis Association.
Just a couple points. If anybody would like to stand rather than sit, please feel free to do so. I know that a number of people would prefer to do that. A couple of things just to reiterate also, again, thanks to our sponsors, both to Spark in this meeting, Novartis, UCB, Celgene, Janssen, Amgen, and AbbVie. Thank you very much. And just one other couple quick announcements. Research is a lot of what we do, as you know. One of the ongoing research projects we're looking at is participating in a health index. One of the questions behind this is how you actually capture accurately the impact on day-to-day living of ankylosing spondylitis on patients, and that you guys are the experts. So Daria Lawson, Daria's right here, she's got if you're interested in participating in this questionnaire, it's a multinational study. One of our colleagues in northern Germany, Uda Kiltz, who herself is an AS patient, is actually leading this study. So we'd like to actually have a strong Canadian contribution to that. The second active study we're doing is Casey Hemington is here at the back there. Casey works as part of the neuroscience program here. And the Casey's interested in studying is how we actually measure pain. As you know from our clinic and other clinics, we do these interminable questionnaires, right? It's impossible. Well, the issue behind that is that we don't have an actual way of measuring pain. And so Casey and her team, Karen Davis, are actually pain experts. They're actually the neurologists that study pain. So Casey's doing a very active project in what happens in terms of imaging pain in the brain. So please feel free to speak to Casey. We'd be delighted to have you participate in these studies. So I'm going to, before we get to the real active non-pharmacological treatment, say a few words about this. So Laura Pastelon's coming up to talk to us about how critical physiotherapy is, and Michael already showed this slide. The reason this is a very important slide is that education about this disease is a lot of what we do in our clinic, because we feel that the more we work as partners with the patients and the physicians and the researchers. Collectively, we'll make more advances. Secondly, particularly for our young patients who all of a sudden are facing a diagnosis of an illness that is chronic, it's going to be with them for years, understanding what some of the true facts and the mythology around ankylosing spondylitis is very, very important. Because some of the websites, particularly the ones you heard today, are very, very valuable, but there is some misinformation as well. So anti-inflammatory agents, the non-steroidal anti-inflammatory drugs. So this covers broadly the class of drugs like Motrin, Advil, Aleve, indomethacin, all those anti-inflammatories that we use. And they're really the cornerstone of the treatment of ankylosing spondylitis. And up until the biologic era, in fact, that's all we had up until the year 2000. But they're still very, very important. And we have a number of patients that we follow in our clinic who actually are doing very well with this combination, the non-steroidal anti-inflammatory drugs plus an exercise physiotherapy program. One of the debates in the research field on these drugs is whether or not they actually can modify disease progression. It's very evident in many patients that once they get on an effective dose of naproxen or Motrin or indomethacin, their back pain significantly improves. In fact, it's often used as part of our diagnostic workup. This is an interesting study from Germany, from Jochen Zieper in Berlin. And what they did was they asked the question, this had been an unresolved question. Should you take your anti-inflammatories on a regular basis? This happens to be a study in Voltaren or diclofenac. Or is it okay just to take it as needed when you feel like it? And the question behind this was some previous evidence that suggests that if you take the anti-inflammatories on a regular basis, twice daily, it actually may slow progression of the disease in the spine. So what Jochen did was he actually randomized two groups. You can see here, this on the left here, the continuous group here. And the other one is on the right is on demand, meaning just taking the anti-inflammatory when you feel like you need it. And the prediction was that actually people that take the regular dosing of the anti-inflammatories all the time may actually slow progression. This study was actually a negative study. Though continuous treatment versus just as needed basis does not seem to differentiate between progression over time. What does that mean in real terms, in terms of managing your pain? Is that we're really guided now by symptomatic control. So on patients that are really benefiting in terms of their back pain and stiffness from their anti-inflammatories, we encourage them to continue that. There's some appropriate health warnings we'll probably come back to in the discussion. But we don't have any evidence to support that it actually modifies the disease. It's symptomatic control is what we are seeking here. Local therapies, intra-articular steroids, of course, if you've had a swollen ankle or a swollen knee or even a swollen hip or shoulder, you're aware that the rheumatologists frequently use an intra-articular injection of corticosteroids. It's actually very helpful sometimes to get you through a really tough period when the joints are flaring. And of course, we follow about 30% of our AS patients have inflammation in the eye intermittently. That's called iritis or uveitis. And we're almost always following those patients with an ophthalmologist, as you're aware. And topical cortisone for that problem is actually very effective. But we really, but for those patients, and again, it's about 30%, that have had episodes of inflammation in the eye, it's very important that we follow those patients together with the ophthalmologists. So these other drugs, sulfasalazine and methotrexate, we put up here. You might have encountered these because they're drugs that are used commonly in rheumatoid arthritis. And they have some effectiveness for peripheral joints like feet and hands, but they've never really been shown to affect the spinal inflammation. So in general, most of our patients are not, in most AS clinics, not taking sulfasalazine or methotrexate. So the big breakthrough really came in about the year 1999, 2000, so we're out about 15 years now with the discovery of the TNF inhibitors, which, as Michael said, came from Drs. Maney and Feldman in Britain. And back then, it seemed rather amazing that we could actually take an antibody, which is produced in a cell, that's why it's called a biologic treatment, and actually inject it in the skin or inject it intravenously and actually block inflammation. I mean, that's sort of routine practice now, but 15 years ago, it was quite a revolutionary concept. We thought that actually it might be dangerous. It might suppress your immune system against infection. Your immune system actually might react against this antibody, and you could have an allergic reaction. There were a lot of fears and concerns when it came out. Happily, the 15 years since then, and now there are 5 anti-TNF inhibitors, or so-called anti-TNF agents on the market in Canada. So you'll recognize the name, infliximab, which is given intravenously. The other 4 are all given subcutaneously by injection. And this has really changed the landscape dramatically. Right? Up until year 2000, all we really had were the anti-inflammatories, and we had pain medication and exercise. That was it. That's not that long ago. So these drugs have dramatically changed the management of ankylosing spondylitis in this time. The other point here is that although we don't have any studies that compare one drug against each other, all 5 of these agents seem to be comparable. So what you see in the red bar here on the left is the placebo arm. These are 4 different studies involving etanercept, infliximab, adalimumab, golimumab. So you can see that the difference over and above a placebo response is very consistent. That's point number 1. So the current understanding amongst the rheumatologists is that all 5 agents seem to be equally effective. So that's important. But there's an important caveat here. Notice that the top bar here gets up to about 60%. So 60% had a very satisfactory response to the drugs, but 40% did not. So these drugs have really been dramatic in terms of advancing the management, but they're not a cure. You actually have to keep taking the drugs. And secondly, we have a substantial number of patients that don't respond to their first biologic. Now, happily, when they go to a second biologic, they often can get that control, but there are some issues around that. This is what's called a forest plot. This actually puts this graphically. Everything to the right of that dotted line there suggests the biologic agent is better than a placebo, and you can see there's nothing to the left there. So all 5 of these TNF blockers actually are very effective. TNF is as B27 is a normal molecule. It's a normal part of our immune system. TNF is a normal part of our immune system. It's a small soluble chemical that the body uses to fight infections. And so it wasn't really created to produce inflammation in the sacroiliac joint, as far as we know. So, but what happens in the situation of an autoimmune disease, the immune system gets, because of dysregulation, starts using these defensive weapons against our own tissues. That's the nature of an autoimmune disease. So TNF is a normal part of our immune defenses, but for some reason, as yet unclear, those defenses actually turn against our own tissues. And that's the nature of an autoimmune response. Good news is, besides changing the landscape, for those patients that do respond, we've been very encouraged by that in many, many patients, once they get onto an effective agent, it stays effective for a long time. So here's a 2-year response. So these are scores. For example, the vertical axis might be the total back pain score. So once the biologic was started at week 0, you can see out to 102 weeks, it's still stable. It's very, very encouraging that many of our patients really do well. This happens to be a study with golimumab one that we studied. Of the original study that was published over 5 years ago, 72% of the patients are still on that same drug, which is really very encouraging. And you see the same message. You see for the right upper corner there, which is the BAS-D, which is an indicator of pain. Once the pain comes under control, at the 5-year mark, it's still under control. It's not always the case, but this has been very, very encouraging for patients and physicians alike, that once the drug seems to settle down the process, it stays effective. So as I mentioned, TNF is actually not produced to make inflammation in the spine or the sacral. It's there to prevent infections. The body uses TNF to kill certain types of organisms like tuberculosis. So one of the concerns at the beginning was, are we going to jeopardize your own defenses against infection if we bring in these TNF blockers? And this happens to be one study. Denny Wallace was one of our spondylitis fellows who's back now, starting up an AS clinic in Southampton. If you're passing through southern England and your travels, say hello. But what Denny did, she looked at all the patients in our clinic with infections to see whether the use of biologics constituted a risk. And that p-value, which is not significant, circular, indicated it wasn't. There were other agents, maybe even cortisone, constitute a more significant risk. But this it really mirrors image data that comes from Europe and the States that has reassured us that in general, your immune system can handle infections. Now, there are a couple of important caveats. As you know, if you've been on a biologic, we always screen for TB. We do a chest x-ray and a TB skin test. We check for hepatitis B infections in the past. And we're very respectful if you develop an infection while you're on a biologic. As you know, we always hold the drugs while you're on a biologic. But the general message about infection risk has been happily very reassuring. So as Dr. Haroon showed this transition over time, that's something to the extent that the MRI, it gives us a visual image of inflammation. So often when we see our patients in the clinic, the question is, do we do an X-ray or do we do an MRI? So they're really complementary tests. The X-ray gives us an indication of how much damage is existing, like how much damage has there been structural change in the sacroiliac joint and the spine. But the MRI actually gives us a more dynamic picture of how much inflammation is presently going on. And it's often very helpful, as you know. If the X-rays turn out not to be diagnostic, the MRI is very important in helping us make a diagnosis earlier. So you can see this, the line above this is these little white areas represents little pockets of inflammation that are driven by TNF. And after 12 weeks of treatment with a TNF blocker, those little white spots have kind of, which is and many times reflects the pain. So as Dr. Haroon said in this multinational study for American centers and ours, the dramatic thing, and Dr. Haroon took the lead on this, not surprising because he's the Young Investigator of the Year award. You'll see, this is really very dramatic from Nigel's paper. If you introduce the biologic early in the course of ankylosing spondylitis, that's the far left, within the first 5 years of disease, you have a far greater impact on slowing progression. And that's why Michael's question was so important. Like, how many people have been waiting 10 years for the diagnosis, or 5 or less? So one of the active parts of our research program is, how do we facilitate early diagnosis? How can we, and it's actually usually not at the level of the rheumatologist. It's patients seeing chiropractors, family doctors, physiotherapists, massage therapists. And part of the challenge for us is how to educate that group of people on the front lines of the back pain to know when to refer patients for TNF rheumatology consultation. Because it's pretty evident if we can treat early, the long-term outcome is much better. Now, what about, so there are 5 on the market now, so this is an important disease across Canada, thousands, even in the province of Ontario, as Dr. Haroon said, there are over 24,000 patients in Ontario with AS. And so it's an important, from our point of view, that's an important unmet need medically. From the industry point of view, that's a very large market. So some of the drugs that have been used, for example, blocking IL-6, which is another small inflammatory molecule like TNF, quite effective in rheumatoid arthritis, turned out not to be effective in ankylosing spondylitis. Ustekinumab, which is called Stelara, is a very effective agent for psoriasis. In fact, it's quite dramatic for psoriasis. And there are studies ongoing now looking at the effectiveness in ankylosing spondylitis. The next 2 agents block a small molecule called IL-17. And IL-17 turns out to be, like TNF, one of the common denominators across many of these forms of arthritis. And in particular in AS, it's a very important aspect of that. These are small inhibitor molecules, and some, for example, the one at the top, and even their Premolast study, which turns out to be quite effective in psoriasis, was not felt to be very effective in AS. So I did include the IL-17 story because at the moment, this agent, which is called secukinumab, should be on the market next year in Canada. And in the original data from Dr. Baton, published now a couple of years ago, you can see that in terms of the pain scores, once the patients, in the left upper corner, once the patients had started on this injection, it's subcutaneous, much like Humira or Simponi, the pain scores really start dropping. So for us, it's really great because we haven't had any biologic other than the TNF inhibitors until this agent, and this will be the next one to come to market. And as you can see here, the control of the responder rate is very good. And in fact, if you look at the right there, it actually, on those original graphs I showed, about 65% of patients are responding to a TNF inhibitor. The impression here is that it might be even a little better here. We're getting up to 70 to 75% are responding to an IL-17 blocker. The other good news is, and you may be a person in this room, you might be in that 40% of patients that didn't respond to a TNF inhibitor. And so we've been waiting, we and our patients have been waiting for alternatives. And the good news here is that if you look on the right-hand bar, these are what we call TNF inhibitor inadequate responders. It's not that you're inadequate, it's just your response is inadequate to the biologic. So many of our patients are really waiting. The TNF inhibitors, either because of perhaps an adverse reaction or a poor response, we've been waiting for some new options. And the good news here is we're going to have some new options in the coming year. So I think this is great. And we're really very optimistic that the IL-17 blocker is not the only one that's going to be on the market. There are a number of our team is here today. I just put up a snapshot of our research team when you're dealing with a multifaceted disease like spondylitis, because it doesn't just produce pain in the back, it affects your work productivity, your exercise, your enjoyment of sports and leisure activity. It has implications for your workplace. And it brings in what we regard as really a multidisciplinary team. So we have people working on regulatory affairs, we have the radiologists, the immunologists, the clinicians, and ideally we're all focused on the same common goal, which is to improve outcomes and improve quality of life of our patients with AS. We're very fortunate at this clinic. We've had a remarkable international presence. We have some here today. Ismail Sari is a rheumatology fellow from Turkey. I think Ahmed Omar, you're going to hear, is a rheumatologist from Libya. And we're very fortunate this has actually turned out to be quite a hub for international trainees. So the great thing about that is we see ankylosing spondylitis as a global perspective. Because many of these trainees, for example, Taiwan Kim, who's gone back to South Korea, has now got the largest AS clinic in South Korea. And so the influence of this clinic has really been spreading. Just let me conclude with just an anecdote here, because sometimes those numbers don't really capture the magnitude of the change. This is a patient we still follow. He had his onset of arthritis in his grade school years. About 20% of our patients start their AS before age 16. And in his grade school years, he was quickly incapacitated. And between the ages of 12 to 15, he was treated in the rheumatology clinic at Sick Children's Hospital with nonsteroidals, pulse steroids, sulfasalazine, methotrexate, steroid injections, braces. Nothing seemed to be getting him under control. And he was referred over to our clinic right at the beginning of the biologic era. And he came over with a course that looked pretty bleak. Here was a 15-year-old kid that was pretty well close to being wheelchair bound. And we started him on a TNF therapy right at the beginning of the era. And here's Chris. A year later, he ran the Chicago Marathon with his father. And it's quite a remarkable story. He went on to be a very elite 10,000-meter runner in high school and is now a physiotherapist who feels called to treat ankylosing spondylitis. So it's those kinds of stories that what we're all about, and certainly is inspiring for us as a clinician as for you. So I'm going to turn it over to Laura Passalon, I think is next. But before we do, if you'd like to stand for a second and just stretch, feel free to do that. We know this is a stretch-sensitive group. So as I mentioned in the introduction, one of the great things about our team is having a multidisciplinary set of expertise. And Laura's our physiotherapist, and she's going to give us an update on the non-pharmacological treatment of AS.
Yeah, stretch it out.
If you prefer to stand, well, Laura won't take it personally. Right?
Not at all. Slideshow. Is that? Oh, we're up. Okay. So I'd like to thank the organizers and sponsors of tonight's event for inviting me to speak to you about non-pharmacological management for ankylosing spondylitis. So your first question might be, what is non-pharmacological management? And I think it's been highlighted already to you tonight. But basically it's everything except pharmacological management, so self-management, physiotherapy, complementary and alternative medicine, diet, education, and probably most importantly is exercise. So most of my talk is going to focus around exercise tonight, so you've been warned. I think this is the third time tonight that we've seen this slide, but basically what it does is illustrate that non-pharmacological management really is a cornerstone in the treatment of ankylosing spondylitis, alongside both the medical and surgical interventions. And no matter where we're coming from in terms of our treatment approach, whether it's from a pharmacological aspect or whether it's from physiotherapy or exercise, the principles of care for ankylosing spondylitis remain the same. We really want to decrease pain, minimize stiffness, reduce fatigue, prevent deformity, reduce cardiovascular risk, improve function, and ultimately improve our quality of life. So what are the scientists saying about non-pharmacological management? Well, as mentioned, exercise is probably the most studied non-pharmacological management. And home-based exercise or supervised exercise is better than no exercise at all, which makes sense. Group exercise is better than home exercise alone, and adding forms of hydrotherapy or water-based therapy to weekly group exercise is better than weekly group exercise alone. The benefits of exercise are numerous in ankylosing spondylitis. We know that it reduces pain, improves spinal mobility, reduces fatigue, improves disease activity and cardiorespiratory fitness. It improves depression, improves function, and as I mentioned, has a big impact on quality of life. But we need to understand that not all exercise is equal. So different exercises affect and impact different body systems. And back in 2011, the American College of Sports Medicine undertook this big scientific review of all different types of exercises and what their effects were. And they looked at this in healthy individuals, and they came up with the following position statement. And I'll read it out to you. It says, "The scientific evidence demonstrating the beneficial effects of exercise is indisputable, and the effects of exercise far outweigh the risk in most adults. A program of regular exercise that includes cardiorespiratory, resistance or strengthening exercise, flexibility or stretching exercises, and neuromotor exercise beyond activities of daily living are essential for the health of most adults." And I highlighted there beyond activities of daily living because it's important that we do focus on purposive exercise, so exercise that is targeted. So a lot of the times I'm hearing, well, you know, I exercise, I walk my dog 3 times a day, or I'm busy with the kids, and this is important to remain active. But if we want to gain the effects of exercise, it needs to be dedicated, and it needs to involve these different aspects that target the different body systems. So these are their recommendations, and I'm going to get into more detail about each of these later in the talk. But essentially, in order to gain the effects of exercise, cardiorespiratory exercise needs to be done at least 3 to 5 times a week. Muscle strengthening 2 to 3 times a week. Flexibility exercise, here this is based on healthy individuals, so we recommend 2 to 3 times a week, but for people with ankylosing spondylitis, I think that that's something that I would recommend on a daily basis, specifically given that stiffness is such a major concern in ankylosing spondylitis. And they also recommend the involvement of something called neuromotor exercise. So what this means is it's basically functional training of the muscle. So if we think about strengthening our quadriceps muscle, and I need to walk away from here, and I was told to use this thing. Can everybody hear me? This is very exciting. I might break out in song. Okay, so in terms of neuromuscular exercise or neuromotor exercise, if we think about quadriceps strengthening, which is this muscle in the thigh, we can go to the gym and we can do leg extensions, where, you know, the weight is on the end of the leg, and we can strengthen our quadriceps quite nicely that way. But it's not very functional. We can also strengthen our muscles by doing, or our quadriceps by doing quarter squats. Now, this is a more functional way of training the muscle because this translates into getting in and out of a chair, picking things up off the floor. So trying to incorporate exercise that is more functionally training the muscle is probably a more efficient way of training the strength. Okay, now I'm going to put this down here. I'm getting my exercise tonight. Okay. So the next question is, we know what the scientists say about exercise. It's important. But what are people with ankylosing spondylitis saying about exercise? So we looked into this back in 2010, and we asked patients in Dr. Inman's clinic, what are their perceived benefits and barriers to exercise, and also what are they actually doing? We took an inventory of what they were doing and how frequently. And what we found is that patients with ankylosing spondylitis very much understand the benefits of exercise, but they also identified a number of barriers in terms of being unable to do exercise. They mentioned that exercise is hard work, I'm fatigued by exercise, and exercise tires me. So these all centered around the concept of fatigue, which is kind of an enigma in ankylosing spondylitis. It's stiffness and pain and fatigue are the three main things that people often report who have ankylosing spondylitis, and fatigue is one of the difficult things that we are able to treat. The other thing that we asked was, what are you doing in terms of exercise and how frequently? And what we found is that the majority of people reported doing some form of home stretching program, walking as a form of exercise, or attending a fitness gym. But what we also found is that they're not necessarily engaging in those types of activities frequently enough in order to gain the physiological benefits. So that means that we as healthcare providers have some work to do in terms of ensuring that people with arthritis really get the message of how important exercise is, and we need to think of ways in terms of how to motivate and facilitate exercise. So then the obvious question is, well, what exercises should I be doing for ankylosing spondylitis? So there's four main principles whenever we're prescribing exercise, and the first is to address posture, the second is stretching, strengthening, particularly core strengthening, as well as involving some sort of cardiovascular fitness program. I'm also going to talk briefly about hydrotherapy or swimming and other forms of exercise. So posture is the foundation of function, but it's also the foundation of ensuring that your exercises are done efficiently. Now, appropriate posture, if you can imagine a plumb line bisecting the ear, through the shoulder, the hip joint, the knee joint, and the ankle joint, that represents good posture. And a wise woman told me once, be proud of your height. This is my mother. And I find that I'm saying it to my kids now, but it's a good piece of advice. You need to be proud of your height, and you need to stand tall. And not everybody with ankylosing spondylitis is going to get into that sort of head-forward kyphotic posture, but if you do, you want to make sure that you're going to maintain the optimal posture because it's going to reduce pain and optimize your function. Now, this picture here may date me slightly, but does anybody know Shaggy? Everybody know Shaggy? Okay, that's good. Okay, so Shaggy is demonstrating here not so good posture. So he's got the typical head-forward posture. He's slightly what we call kyphotic or hunchback, and he needs some work. So I'm going to be using Shaggy as an example throughout my talk. So the first thing we're going to talk about is stretching. So, in order for stretching to be effective, it needs to be done on a daily basis, and this often helps with morning stiffness and stiffness that is associated with ankylosing spondylitis. When you engage in stretching, it's important to respect your pain. So I often advise patients to just take the stretch to the point where you start to feel that discomfort and then hold it there. And it needs to be a slow and prolonged stretch for a good 20 seconds in order to get the effects. You don't want to bounce, obviously, as that can cause some potential injury. And you want to make sure that you breathe in order to increase the efficiency of the stretch. So here's Shaggy again. So the areas that you want to target are the pectoral region, so that's the front of the chest, the abdominals, the hip joints, as well as the neck, the hamstrings, which is in the back of the thigh, and then the calves as well. Now, I obviously don't have time to go through all these stretches with you, but I just picked out sort of one or two to review with you. So this is a cat and camel stretch, and I like this stretch because it targets the entire length of the spine. It gets the neck, the mid-back, and the low back, and it also works on the shoulders and the hips. It's an easy stretch to do. This is a stretch that they often do in yoga as well, and it's very effective in terms of getting the whole spine. Another important stretch is the hamstring stretch. So these are your hamstrings back here. And I'm going back over here to my Okay, so the hamstrings is behind the thigh, and they go from behind the knee, and they insert into the buttock. Now, if the hamstrings are tight, what they're going to do is they're going to, and I'm exaggerating here, pull the pelvis backwards. But we're obviously not going to walk around like this. We're going to compensate by flexing our spine forward. And that's going to encourage the sort of forward flexion that we want to avoid. So by ensuring that our hamstrings are stretched out, it's going to keep our pelvis in a neutral position and allow us to stand in a good posture. Make sense? The other thing, too, I want to point out here is that there are different ways of stretching the hamstrings. Some people will do it in standing, leaning over. Don't really recommend that because it puts a lot of pressure in the low back. This is a little bit more back-friendly because your back is supported when you're lying down, and you can use a towel or a belt to help facilitate the stretch. I don't recommend using the TheraBand because it's a little bit too bouncy, and again, you're apt to injure. Okay. Over here. Okay, so strengthening. Particularly core strengthening is important, so that's where you're training the abdominal muscles and the back muscles simultaneously so that they can support the spine. Strengthening should be done about 3 times a week, and again, you want to ensure correct posture when you are strengthening. And you want to ensure that you're activating the correct muscle group. So very often, certain muscles in our bodies will overpower other weaker muscles. But it's sometimes those weaker muscles that we really need to train. And it's difficult to kind of know that on your own without somebody who understands exercise, who could be instructing you, such as a physiotherapist, kinesiologist. So we do rely on those people's expertise in order to ensure that you're doing the exercises properly. The other thing is that we want to progress our strengthening exercises from easy to advanced. So the reason for this is obviously we don't want to injure ourselves by going at it too hard too soon, but also too we want to ensure that once you gain good strength that you keep pushing yourself to the next level, and that's why it's important to go on to an advanced form of the exercise. And then if you can incorporate it into your daily function. So here we've got Shaggy again. So again, we want to work on our abdominals, our neck stabilizers, our buttocks, the back, of course. Oops. And again, just the back and the abdominals will be working together to improve the core. So we want them to work synergistically. And I'll explain that in a minute. So here's an example of a remedial exercise for both the abdominals and the buttocks. So this is a pelvic tilt. And then this is a more advanced version of the same. So it's working the abdominals, it's working also the back muscles and the glutes. And the glutes are the butt muscles. And sometimes people with ankylosing spondylitis will have hip involvement. So ensuring that the glute muscles are really strong are going to be important because the stronger your glutes are, the less pressure are going through the hip joint. So here's an example of some typical core strengthening. Does everybody do this? Good. Okay. And so this is a remedial version. So this is the core working together, so the back muscles and the abdominal muscles, and then this is a more advanced version of the same. Now, how many people have exercise balls out there? Oh, not too many. Okay, I love the exercise ball because it is so diverse. There's 10,000 different exercises that you can do on it, and it is an excellent source or an excellent form of exercise in order to improve your core strength. Just simply sitting on a ball engages your core. So I will often recommend that people, that's my husband on the left. I'm sure he doesn't appreciate me showing straight, anyways. So just simply sitting on a ball will engage your core. And I'll often recommend that people sit in front of the TV. You can watch your TV, but you sit on a ball and you're working your core. And at commercials, you can do leg lifts, which further challenges your core muscle because it's more of an unstable surface, so the core has to engage to prevent you from falling over. And that is a good form of exercise. The other thing is you can sit on a ball at work quite easily. The key thing with the exercise balls is to make sure that you're sitting where your hips and knees are at a 90-degree angle. And the majority of people can get away with a 65-centimeter diameter ball. You can buy them anywhere now. Before, years ago, you had to go to specialty fitness stores, but now you can get them at Winners, Canadian Tire, wherever. So no excuse. Next year, everybody's going to have their hands up. Okay, cardiovascular fitness. So this is important for, as Dr. Haroon mentioned, that people with ankylosing spondylitis have an elevated risk of cardiovascular disease. So we need to make sure that we're addressing that body system with appropriate exercise. You want to make sure that you focus on low-impact activities. So that means things like brisk walking, cycling, elliptical machine. But that being said, we do have people with ankylosing spondylitis in Dr. Inman's clinic who are marathon runners, and they seem to be doing fine. So if that is the form of cardiovascular exercise that is going to motivate you to get out there and exercise, then go ahead. We recommend that you engage in it 3 to 5 times a week for at least 20 to 60 minutes. And you should be working at an intensity of 55 to 90% of your target heart rate, which is a little calculation there of 220 minus your age, and you take the appropriate percentage. The easiest way to figure that out is if you're engaged in a cardiovascular form of activity, you're sweating, but you're able to maintain a conversation, you're likely working within your target heart rate. Swimming is a great form of exercise because it combines cardiovascular fitness, core strengthening, as well as mobility. But some people may say, but my neck really hurts, the spondylitis affects my neck, I just can't picture myself breathing when I'm doing front crawl, so how do you expect me to swim? So it turns out that one of Dr. Inman's patients, a number of years ago, he goes to the gym, his neck, I think, is fused, he goes to the pool, his neck is fused, and he gets around this by swimming with a snorkel and mask. And really, it's an excellent tip. This is, Dr. Inman mentioned that we learn from patients, and now I recommend that anybody who's got stiffness in their neck and they want to engage in swimming, this is how you do it. Other forms of exercise that are good are yoga, Pilates, and Tai Chi, again, because they combine the core strengthening with the mobility, and in some cases you can even get a cardiovascular fitness, for example, through yoga. If you do the repeated asanas, the sun salutation over and over again, you actually get a cardiovascular benefit from it. Just some things to consider. So fatigue, I mentioned. It's one of those difficult things that we're trying to get a hold on in terms of ankylosing spondylitis. Exercise is effective if you suffer from low to moderate levels of fatigue. So if you're tired, push yourself, because over time you will gain some benefits in terms of diminishing your fatigue as a result of your ankylosing spondylitis. The other thing too I want to mention is medications. So we know that the biologics are extremely effective, but it's important to keep engaging in regular exercise even though you're feeling great on your biologics, because we know based on research that exercise and biologics have a synergistic effect. So people who are on both, on biologics and exercising regularly, had improved disease activity, reduced pain, improved mobility compared to those people who were just on biologics alone. So it's important to maintain your level of exercise while on your medications. And just a few things in terms of accessing physiotherapy in Ontario. There is OHIP-covered clinics, so these are designated physiotherapy clinics. They are specific clinics, and you can go on to the Ministry of Health website to find out which clinics are located around you that are OHIP covered. The caveat is that you have to be over the age of 65 or under the age of 19 or on social benefits or an overnight stay in a hospital. So it is a limited access in terms of publicly funded physiotherapy. Otherwise, you're looking at private physiotherapy. This can be covered through extended health care insurance, or you can pay out of pocket. There are exercise programs that are available out there. There's great programs in community centers as well as private gyms. And the Arthritis Society, I have to mention Mary Eisen, there she is. They offer services, so occupational and physiotherapy, as well as social work. And they have a number of fantastic programs offered to people with arthritis, so I suggest you go on their website and take a look. So I'm just going to mention briefly some other forms of non-pharmacological management. So Michael mentioned patient education is really important, and we've seen this as a gap, particularly here at the Toronto Western Hospital. So in an effort to fill this gap, we developed an e-learning online module that takes you through how to understand ankylosing spondylitis in terms of symptoms and diagnosis, treatment, how to manage it. It was developed by an interdisciplinary team of occupational therapists, physiotherapists, rheumatologists. We had spiritual care, pharmacy, and there was one other person I'm missing. Oh, dietitian was involved as well. But most importantly, we had patient partners involved with the development of this website. And it's not yet live because we're still in the study stages of it. And here is another research plug. But if you're interested in participating in this study, so we're looking at the impact in terms of disease activity, self-efficacy, which is how confident you feel in being in control of your disease. We're looking at a number of other outcomes. If you're interested in participating, Daria, there she's waving, stand up, Daria. Please approach Daria and she'll give you some more information on the study. But we're hoping to have it publicly disseminated within the next few months. And this shows you some screenshots of the e-learning module, and it's multimedia. There's exercise video as well as patient testimonials available on this website. And then lastly, I'm just going to mention briefly about complementary and alternative medicine. So we know that approximately 90% of patients with ankylosing spondylitis have reported using some form of complementary and alternative medicine. Unfortunately, we don't have a lot of scientific evidence to understand how it works in ankylosing spondylitis, so we do borrow from other areas of rheumatoid arthritis and mechanical back pain. And we know that particularly massage and chiropractic intervention is good at pain reduction and improving function. And there are some what we call natural herbal products that also help with pain reduction and improving function. And I just want to mention one thing about chiropractic intervention. So chiropractors are very good at prescribing exercise. They're a good resource in terms of education, but we also know that they manipulate. And I want to tell you that physiotherapists also manipulate the neck as well. So we do caution you to inform your practitioner if you do have ankylosing spondylitis that they are aware of this, because we don't recommend manipulation, particularly of the neck. If you have syndesmophyte formation, so bridging of the neck, or if you have osteoporosis, and that's for obvious reasons. So I'm just going to end it there, and I believe we'll be taking questions at the end.
So just to remind you, in your packages, you do have those blank questionnaire forms. So we're going to have a panel discussion, so we hope that you'll be jotting down your questions. If you've got them, the area will be circulating. Just pass it down to the end of the row, because we really would like to hear from you. So this is a presentation that is a first for us, because we want to be up to speed on social media. Fortunately, we got somebody on our team who really is up to speed. So Dr. Ahmed Omar is an AS Clinical Research Fellow with us. Happens to have a real interest in social media and patient education. So, Dr. Omar, thank you.
Hi, good evening, everyone. I'd like to thank the organizers as well for inviting me to speak today in a kind of a topical subject, social media. But before I start, I'd like to ask the audience just 2 or 3 questions. How many of you in the audience actually use social media such as Facebook, Twitter, or any other? Fair amount. And how many of you use these tools, online tools, to get some education in terms of healthcare? Excellent. That's a good amount. Okay. So what I'll be doing is I'll be kind of giving you an introduction. I'm sure there's a few of us here who may just need a bit of introduction about what tools are available out there. But my focus will be towards the end about Twitter in particular. Okay. So basically, what is social media? So a lot of us may think, who are not using it, they keep hearing about its use to follow certain entertainers. For example, this fine young gentleman from Canada. So a lot of teenage, probably girls would use Twitter to follow the latest news about certain entertainers. Or maybe there's this slide that I actually borrowed from a website where they actually tried to explain certain social media outlets in a kind of funny way. I did actually amend this. Sometimes social media is used, a lot of people think it's used for boring topics like updating people about their daily habits. For example, I amended this. The original slides actually showed people going to the toilet, which is something apparently people like to declare, which I'll show you a bit later on. So Facebook, for example, like eating. Well, maybe in Facebook you'll say, well, I ate today, and then you'll tell your friends about that. YouTube, look what I ate, showcase it. Twitter, I need to eat now. Or LinkedIn, I'm actually good at eating. So LinkedIn is actually a social website where you can actually showcase your talents, especially for job seekers. Okay, and then there's Foursquare, which I don't use, which is actually about location. This is where I ate. Okay, so to be more serious, when we look at social media, this is one definition that I found. So social media is the interaction among people in which they create, share, or exchange information and ideas in virtual communities and web-based networks. Okay, so in essence, to make it really simple, social media is about communication or conversation. Instead of having forums where we meet and talk together, we can do it online by various tools. Okay, they may differ a little bit in the way that they are showcased, but in essence, they are about actually having conversations. Okay. All right, in our kind of paradigm or in our kind of context in healthcare, these conversations can either be peer-to-peer, so for example, like patient-to-patient, where you can actually network with other people, for example, who have ankylosing spondylitis or arthritis. Or us as healthcare providers, we can actually communicate with other healthcare providers, either locally or internationally, or across the board, where we can actually, which is I think is valuable for us, especially as we know about these tools, for us healthcare providers to communicate with you directly as well online, okay, which we'll talk about in a second. Now, when this diagram or this cartoon just showcases the way that people behave in terms of when they use social networks. So there are kind of 5 broad categories. So some people actually broadcast. That means they put stuff out there without actually expecting or wanting any kind of feedback. Okay. Some people put material out, create content, they place it out there, and then they expect some kind of feedback, and then so they can benefit and actually improve their content. And then you have observers. They like to read, but they don't like actually to provide. They don't want. They don't want to provide any feedback. They just want to read. And then we have the category where people can read and provide feedback. And the last category would be people who actually want to compare themselves with other users as well. Okay. All right. This is this shows. I'll explain what this means. Basically, this shows. If you look at where the number 1 is, this is the traditional internet, which actually which everyone started to use in the early 90s, which is called Internet number 1. So basically, what it is where institutes here began to provide content, and you would log on to the internet, you would look at that web page, and there's no real interaction with the content providers. You would just read, that's it, or maybe see something. Okay, and then in the mid-2000s, 2004, 2005, Web 2 came in, where actually even the consumer can actually create content, like we do now with Facebook or Twitter or blogging, which is the first one that really came into the scene, where you can actually create content, place it in there, and then you'd expect the people who actually follow you or who read your content to actually provide feedback and so on. So there was a two-way kind of traffic. Which revolutionized the way we actually looked in how we use the internet and how we actually benefit from it. And then where we look at number 3, this is going to happen in the future. And this is going to be exciting actually, because as technology improves, as the interface the interfaces like laptops or mobile devices become more powerful, we can start using things like artificial intelligence, voice recognition software, where you can actually speak to whatever interface that you need. And then with improved search algorithms, you can actually network with more people, and these new services will be able to provide more content in a more meaningful way. So things are developing rapidly, thankfully. Okay. So what we know is that there has been an impressive increase in social media use over the years, especially over the last few years. And this actually has fostered discussion, and it has eased the dissemination of information as people who use social media outlets such as Facebook and Twitter know. And then in terms of healthcare, patients already are actively involved in its use, and they're learning and discussing their healthcare needs with either themselves or with healthcare providers. And actually, from the evidence, it looks like the healthcare providers are not as active as they should be. There is a little bit of lagging behind, but as we know that usually you are the drivers of research and you are the drivers of these things, and we actually look up to you in terms of using these tools. And also there is actually a benefit from us as well, because it can actually enhance physician to physician and healthcare to healthcare or scientist to scientist interaction. So these communications are extremely important, as we'll see. Okay, so we're going to talk about demographics of social media. So who's using social media? And just before I go ahead, I'd like to explain what demographic means. So this term actually is just like basically what it does is what it means is quantifiable characteristics of a given population. So for example, when we look at gender breakdown or age or maybe education, so all these things are considered under the term of demographics. Okay, so the Pew Research Foundation, which is from the United States, actually looks into this on a yearly basis. And what they found is over the last several years, specifically from 2005 until 2015, over the last 10 years, we know that there's a 65% of adults actually use social networking sites in the United States, which is fairly representative. Canada's not too dissimilar. Okay, so there's been a nearly tenfold jump in the past decade. In terms of age, there is an age difference. That's probably expected. Young adults, which is defined in their kind of research as between 18 to 29-year-olds, are the most likely to be active or the most likely to use social media. So they actually quote 90%, which is a large number. But, however, among patients who are 65 years and older, there has been quite a steady increase. So from 11% in 2010, just a short period, who use social media, now actually 35% of 65-year-olds and older actually are using it. So there's been a huge increase as well in that patient subset, in that group subset. Okay, this is basically a graph that actually showcases. So the blue bars are the more younger population, and then the green is the more mature populations. And it just shows that there has been that the seniors are making quite a lot of strides. So it's not just young people who are using it. Okay, so in terms of gender, there's not much of a difference. Actually, 68% of females versus 62% of men who actually use social media. There is a little bit of a divergence, but it's not significant. Okay. So what about internet access, and what modalities do we use to actually access these websites? So we know that not everyone has a computer, but many people have cell phones now, and actually in the States, 91% of adults actually possess a cell phone, and 2/3 of cell phone users use the internet, and 56% of Americans have smartphones, and I'll look into the Canadian data in a second. So in Canada, in 2012, 83% of Canadians or Canadian households actually have access to the internet at home, compared to 79% in 2010. So there's a steady increase. And this just shows smartphone users in Canada from 2014, which is last year, and the expected increase over the next few years. So there's about a 50% of our population actually use smartphones, and it's increasing steadily as well. Okay. In terms of Facebook, I'm just going to concentrate on Facebook and Twitter. 71% of online adult users actually use Facebook, which is a huge amount, and 23% of online adults use Twitter. Okay, this just shows you how much Twitter and other websites like YouTube and Facebook, the populations that we're talking about. So Facebook is 1.3 billion people actually use Facebook. They're monthly users. YouTube also about 1 billion plus. So Twitter, about 500 million. That's 500 million people, okay? So there's huge populations. The conversations are out there, okay? This just shows you the difference between Facebook and Twitter. So the launch dates of, in terms of age, they're very similar. And then I think if there's one probably to concentrate is the difference between the two. They're very, very similar, and they actually, because of the new updates for both networks, they're becoming more similar actually. So Facebook kind of networks people, but Twitter networks ideas. That's the main reason, and I'll go into what Twitter is in a second. So in terms of tweet stats or Twitter stats, so every day there's about 500 million tweets generated every day, microblogs. That's a huge amount. Every second, that's 6,000 tweets per second. Okay, that's a huge amount. So even if we say that 1% of tweets are important, that's nearly 5 million tweets. So there is a fair amount of conversation going on, just by the use of one portal, which is Twitter. So it just shows you how much information access is available to us, and live as well, because these things have been updated by the second, literally. Okay, so if we talk about Twitter, just to give you a bit of background on this portal. Okay, so I'm just going to give you some general descriptions. So what is Twitter? It's a free social networking website, and it's basically, you use it for microblogging. Why microblogging? Because it has a character limit. So instead of writing away like in Facebook, this only allows you 140 characters. So it has advantages and disadvantages. It allows very clear messages, succinct, but you can actually, there's ways of working around the limit as well. For people who use it, they know how to do that. What can we do with it? So this just explains to you about the 140 character limit, and And then people can actually, you can actually share ideas with other people, and people can actually subscribe to your ideas, and those subscribers will be called followers, okay? And then, so senders are people who actually, if you receive a tweet that you like, you can actually retweet it to your own followers, you can share it to other people, so you can disseminate information in a very kind of rapid and efficient way. So what separates it from other things? It's simple, it's quick and frequent. Actually, there's one analogy that people use is Twitter is more almost like being invited to, or not maybe invited, or you can invite yourself to a cocktail party. You can just go in, you listen to the conversations, and you can choose to engage if you want to. And you can carry those stories that you heard to others if you feel that they're interesting. It's less pressure, so that means you don't really have to engage. With people, you can just listen, or you can engage if you choose to do so, and it can be personal as well. Okay, so this is just a bit of a glossary. I won't go through all of it, just because of sake of time. So we talked about Twitter. We talked about a tweet means a message that you post on Twitter, and that @ sign, which you use for emails, this is a sign that you use to mention other users. So, for example, Bill Gates, if you want to mention him, you use that @ sign in front of that person's username, and then when you tweet that, people will know who you're talking about, and then that individual will know as well that he's been mentioned, and he can actually track that Twitter he's been mentioned in. So hashtags, this is probably one of the most important terminologies. So the hash symbol, okay, is used to highlight keywords or topics. And so, for example, we recently attended an ACR meeting, which is last week, which is probably the biggest rheumatology meeting in the world. Annually, it's held annually. It was in San Francisco, and people were using the hashtag ACR15 when they're tweeting, and especially people who are participating in the conference. And when people actually search for that hashtag, then you can actually know what's going on in the conference, and it gives you a focus. So when you use certain hashtags, you can actually flag certain ideas, for example. And these hashtags you can create yourself. So things like arthritis, AS, news, whatever you want to do. Okay? You can put links on your tweets. And then, as I said, the other ones are like followers, and we explained that. Okay? And you can actually reply to Twitter, certain tweets as well, if you please to engage in chats. Okay? This just explains the anatomy of a tweet. All right? As many of you do actually use it, you would be familiar with this, okay? So this just showcases, so I just kind of, to explain to you how Twitter could be useful. So for example, if you, the red box there shows a search bar, and I actually searched for the hashtag spondylitis, and the results actually show there, and it actually, first what it does is it actually gives you the top results. So for example, like spondylitis.org is a website or an organization that's well known. So it links you to that as well. And below it, you can actually see some of the posts that other people are using. And actually, you can actually scroll down to see what people are posting under that hashtag, okay? And actually, one of the pictures there, where there's a gentleman there with standing in front of a poster, is actually one of our former colleagues who trained under Dr. Inman. Actually, I don't know how to use this. There we go, here. So you can actually even engage and network with other people as well. Okay. So remember when we talked about toilets previously? So I just did a random search. These are rheumatology doctors I follow, and lo and behold, the theory was true. I actually found this picture, came up on the top there. So this is what your timeline would look like for people who you actually follow, and you can actually read their tweets and see what's going on. So it can be used for feedback. So for example, NAS, which is a British organization called the National Ankylosing Spondylitis Society in the UK. So you can use it for feedback. Here, they tweeted out something for their followers. They wanted to ask other people how they can actually improve their clinic visits or their clinic needs. Okay, they can disseminate information like education. So here they're sharing an infograph about ankylosing spondylitis. So you can actually, if you follow reputable organizations or people who are trustworthy, you can actually get very good information. Okay, So this again just shows you some education. Laura just spoke about physical exercise. You can get information that's fairly up to date and easy to digest. All right. It can raise awareness about arthritis. For example, here the Arthritis Society has a good Twitter account, and lo and behold, I think you can actually get very good information. And then peer-to-peers like patients, you guys can actually ask questions as well. I found this tweet while I was actually randomly searching, and this particular patient wanted to ask fellow patients what they thought about Celebrex, okay? And he engaged in a chat, and people actually provided some feedback. Some thought it was helpful, some didn't, okay? And then this is from Arthritis UK. They wanted people to share their arthritis societies, their arthritis stories. And a lot of people replied, and they provided actually some very nice stories about what they're going through. And so that was educational as well for me. And then we can share new information. Here, Dr. Inman's talk in the ACR this year was actually shared on Twitter as well. People just kind of focusing on important points. Okay? And you can actually get very interesting things that I would never have thought of, and which is actually important. Exercise, right? You can actually get exercise by walking your pet, like a dog or something. So this was very interesting, I thought. I never thought about this before. So you can actually get very maybe novel ways of looking at our conditions or how we can actually manage them. So here there was a question as how does your dog help you to manage ankylosing spondylitis? And people actually engaged, and okay. Now the other important facet that these kind of social media networks can do is they can help filter out information. Just to give you a bit of a summary of how much information is out there every year being published in medicine, for example. So in 2014, there were more than 5,000 journals being indexed by NIH, Library of Medicine. And there were nearly 1 million citations. That's just about over 700,000 citations. So there's huge amounts of information out there. Now, one way of filtering that out is, while I'm in clinic, for example, when I'm with Dr. Inman or Dr. Haroon, I can sit with them and part of the ways that we learn as fellows is, they will guide us about what's going on out there in the field of spondylitis or arthritis or rheumatology. And actually we get some training on how we can actually filter out the available information, and also get some tips in terms of what to read or not. It'll be great if we can actually have that online, freely available to everyone. And one way that social networking can do that is you can get professionals or maybe some other very prominent scientists who can actually share information, share important articles and what scientific updates with fellow colleagues and as well as patients as well. So Dr. John Cush, he's a rheumatologist from the States. He's very active on Twitter. So for example, he is sharing a JAMA article. JAMA is one of the leading journals out there. This is another rheumatologist from the UK, just sharing some kind of important updates about rheumatoid arthritis, for example. And there is actually a discussion out there. Some people can actually reply and ask them specific questions. And sometimes the authors themselves of certain articles can actually share important information as well about what they've published. And they can actually receive feedback and give more detailed explanations. Okay? Leading journals as well can actually share information about what they've published. So these are all important facets, I think. Campaigning and fundraising. We talked about campaigning and fundraising for our own institution here in Canada earlier on, and about funding research in spondylitis. One way that we can do that is to raise awareness through campaigns like the Arthritis Society does as well. Okay, like crowdsourcing or, okay. Okay, and then social media can provide informal support groups for people who suffer from the same chronic conditions. Okay, it can raise awareness, as I said, it can provide education, which is an important facet of management. You can, talk to a community of bloggers, whether in Twitter or elsewhere, and then you can actually get tips from about lifestyle, health maintenance, support. This is very especially important if you live in a more rural setting where you don't have access to regular healthcare or community centers or kind of more physical places that you can go to get information. So Twitter can actually provide that for you, or social networks can do that. Okay, so things that can be talked about, diets, etc., exercises. Okay, and then caregiver support. Let's not forget caregivers, because they are important as well, and they can actually also receive support online. Okay, and in terms of us, like healthcare providers, it provides us, I think, a great opportunity to communicate with other people and yourselves, as we said before. And actually, 1 in 4 doctors, about 25% of US doctors, for example, actually use social media on a daily basis to scan and explore medical information. Okay, 7% from what we heard from the evidence from this article use Twitter, maybe higher, we're not sure yet. Okay, scientists also use it, including physicians, and these are the realms that they actually look at. Discover recommended papers, comment and research. And there was one very interesting story I heard yesterday when I was reading. There was a scientist in Africa who was running a lab, a microbiology lab, and he wanted to run some samples. I think it was fungal samples. He wanted to do some specialized testing. Apparently very important work in his context in Africa. But unfortunately, he didn't have the facilities and he couldn't afford to do it. He used one of the social networks, which is called ResearchGate, online, and actually somebody responded from Italy, and he offered to collaborate with him and to take the samples and to run them for free at no cost to this gentleman, this scientist in Africa. And then a new collaboration was born, and new data was actually gained and garnered and used in Africa. So it has an immense effect on the scientific community, and I think it has a great deal of strength in terms of providing a great deal of good overall internationally as well. In terms of rheumatology, there has been a substantial growth. This is a poster that we presented in the ACR meeting last week that we talked about earlier on. And from 2000, we looked at Twitter usage from 2010 and onwards, from almost non-existent usage of, in terms of Twitter hashtags related to rheumatology in 2010 to about 500,000, last year, 2014. So there has been an immense and sustained growth. And actually a lot of it is driven by you guys, the patients. Okay, so compared to other specialties, we still lag behind. For example, like diabetes hashtag, we still lag behind. We're almost 50%. So other hashtags like breast cancer, for example, it's way off the chart. People are very active discussing cancers, for example. And then in terms of AS, when compared to other hashtags related to rheumatology, we're still lagging behind compared to lupus, for example. So there is scope for improvement, and we hope you can be more actively involved, okay? So to sum up, in terms of advantages, staying informed, it actually provides you that platform of connecting with others, and maybe even leaders in research internationally and nationally as well. You can share what you learned with others, you can contribute and provide content, and then you can network with both patients, your peers, as well as other kind of professionals, okay? Okay, so there are disadvantages, obviously. So privacy, obviously sharing your information online can have its pitfalls, and please do be careful. And there are websites where they can actually, it will guide you on how to best use these kind of platforms as patients. And in terms of us, for patient providers, there is a challenge as well. Do we provide personal medical advice? The current medical regulatory agency still recommends against that, obviously, for obvious reasons. So there are sensitivities out there, and there are legal challenges as well. But I think these things will be ironed out with the continued usage, with the feedback that we get. I think the overall advantages definitely outweigh the disadvantages that we see. Okay, but I think it's not just, I mean, although social media is important, and I think it is an important tool, it is still important to physically be in connection with your peers as well as the physicians, okay? And as we know, knowledge is power. Knowledge education is part of the treatment plan. No prescription is more valuable than more than knowledge. This was quoted by Dr. Koop, the former United States Surgeon General. I think the future is bright in terms of using these modalities. And we certainly were thinking of actually setting up our own Twitter handle here in our department. And we're looking into researching this and maybe engaging you guys as well. Okay, so the conclusions, the Twitter usage is increasing substantially. It is a valuable tool, as we talked about, and then we should actually consider using it despite although we have to be aware of the potential ethical and medical legal challenges, the overall advantages outweigh it, and then we should actually all join the conversation. And you never know, there may be advantages, like this cartoon shows. One of your tweets may turn out to be something important. Okay. And I'd like to thank you, everyone. I'd like to thank you. I'd like to thank Dr. Inman and Dr. Haroon for an amazing opportunity to train with them, and obviously the opportunity to serve you as well. Thank you very much.
Could everyone please stand up for a quick stretch? We're running a little behind time, and unfortunately our patient speaker, Janice Plethybridge, is unable to attend tonight, but we do have a patient in the audience here who's agreed to speak for a few minutes about himself. His is an incredible story. Andrew Turner has been featured in the Globe and Mail on an article about ankylosing spondylitis. He lives in Toronto, has 4 kids, works in the investment business, and believe it or not, he's run 2 half Ironman. Andrew, over to you for a few minutes. Thanks.
Hi there. I'll be quick so we can get to the Q&A with the panel. Dr. Haroon wanted me to come up briefly and just sort of go through my experience with ankylosing spondylitis. I was diagnosed when I was 37 years old. I'm now 44. And for me, I never really had any prior back issues. I remember I used to sleep on the floor because I had some issues with soft mattresses and whatnot, but there was no noticeable issues that I had with any sort of arthritic condition. And it was a lucky diagnosis in the sense that I had a bulging disc. I went to sit down in a roller coaster and I sort of felt something pop in my back, in one of the joints there was a bulging disc. And one of the radiologists to the sports physio guy I went to just highlighted AS ? Maybe you should do the gene marker test, which I did, and I was positive. So they're going, well, most likely we got to do another x-ray. We'll do one of your SI joints. It was fused completely, so they were pretty confident that it was ankylosing spondylitis I had. And at that point, it wasn't much of an issue for me. I was still running. Once the bulging disc got sorted out, I was doing a lot of yoga, and about 6 months later, I was able to run again. I was a big runner at that point. And then I had a knee issue, which I was on a stationary bike. My knee, there was a cartilage issue and a plaque issue in my knee, and it just ballooned up. I got my knee scoped, and there was an autoimmune response to that surgery. I came out of it, I couldn't straighten my leg. Quite soon after that, both my ankles swelled up. All my periphery joints started to go haywire. Both ankles, both knees, my rib cage, if I sneezed, there was terrible pain. And then my whole system went into sort of overdrive. My hemoglobin levels were crashing down because it was trying to cut off the supply to the disease in terms of the iron stores. To the point of almost blood transfusion. So this was all a pretty precipitous slope. So then finally I got into Dr. Inman and all the NSAIDs. I was on Celebrex for a while, and these things quickly were not working. So in a sense, the fact that it was such a dramatic downturn almost helped me get onto the TNF blockers quicker. The final straw, I guess, was I fainted in the shower because my hemoglobin was so low. I got up and just the sort of blood sort of flow out of my head, and I passed out in the shower. I was taken to the hospital, and they were sort of going, "Listen, your levels are getting extraordinary." I took time off work. you know, and it's funny it's a humbling experience coming to, you know, a patient forum like this, because there's so many degrees of severity to the disease, and I feel like I've been lucky that I found medication that has worked. You know, because the common bond for all of us at one point or another, we had chronic pain and associated depression and the psychological impact that comes with it for the family and for yourselves. And I just hope that, you know, everyone here, you know, finds some pain medication that does work for you guys, and that, you know, maybe next year with this new drug coming out, some more guys will be able to be treated. But as soon as I took the first injection of Enbrel, so it was December 22nd, 2009, I was, at this point I wasn't walking. They were threatening to do an osteotomy on my leg because I couldn't straighten it. They were trying to take a piece out of my femur maybe so I could straighten my leg going forward. And prior to doing that, I tried this drug, and within 3 weeks I was skiing again, and I was running races again in the spring, so in April, so about 4 months later. And I'm now doing, I was doing personal bests in the 5K and 10K running races prior to when I got sick. So there was, you know, I was sort of like the poster child for, you know, these drugs working. I realized it doesn't work for everybody. There's 40% out there it doesn't work for. But, you know, I wouldn't have had my fourth child if it wasn't for, you know, the Enbrel, because it was a bad place for a while. And I understand where a lot of you guys are. And if you haven't found some pain management or some, you know, medicine that works, and I've run a couple of half Ironmans since I've been on the drug, and I continue every couple of years I'll do one just to stay in shape. I will point out, you know, there have been some infection setbacks. I'm more prone to getting my colds are sort of longer, deeper. I've gotten gum infections I never used to have. You know, there was a cold sore outbreak. There's certain things that came along with the TNF blocker. There was some side effects, but by and large, it was well worth it. And to this day, you know, I've been on it 5-6 years now, and you know, I'm proof that, you know, all the research that Dr. Haroon and Inman and all the rest of their team have done, it has helped and does work, and I, you know, hope that research continues. And I wish all you guys the best, and that you all find some solution for your pain. Because I was there, albeit not for a long time, but there was a moment of despair there where I thought, you know, I'm never going to be working again, and how am I going to support my kids and all this. So with the help of the research community, I think we'll all be able to live more full lives going forward if, you know, things work out as they should. So that's my story. And I just hope that we can keep moving forward. And Dr. Inman and Dr. Haroon have been my doctors for the last 5 or 6 years. I appreciate all your help.
Thank you very much, Andy. This is really for many of us, it's the most important part of the evening is here. The challenge of living with spondylitis. So perhaps if you guys want to take a seat, we got 2 chairs. Okay. So thank you very much. If there are any additional questions, please feel free to pass them up. Laura, do you want to start off? There's a couple of questions there, and if there's something you missed or something outrageous that said, feel free to grab a microphone and raise the question before.
Oh, you got quite the pile there, I see, eh?
Yeah. Okay, Laura, you got a couple of questions.
Okay, so the first question is, in case of deformation of the spine, is there any chance to improve it or bring it back to normal form or not? So this was actually posed to both you and I. So from a soft tissue perspective and from a structural perspective of the spine, we can't change the fusion of the spine, obviously. However, very often when we develop these head forward and kyphotic postures, there's a lot of soft tissue involvement so that the muscles get tight. So definitely you can improve it in terms of doing appropriate stretching. You might not get back to normal, but certainly you can optimize it with appropriate stretching and strengthening of the muscle groups that are involved. In terms, and Dr. Inman, do you want to address this part? In terms of the fusion, did you want to talk about
As far as
surgery?
we know, the biologics, once the sacroiliac joint is fused, or if you've got one of those bridging bony fusions across the vertebral body called syndesmophytes, they're there to stay. We don't have anything that can turn the clock back now, right? And so what our best chance is to prevent further progression at the moment with the biologics. So that's
Did you want to just talk a little bit about surgery?
yeah, so we do have, the surgeons are part of our team. There are two indications for in our clinic, the surgery. One is a total hip replacement. So we've had some terrific success where sometimes the spinal arthritis is under control, but the hip, particularly in some of our young patients and where the disease starts in the teenage years, they've done very well with hip replacements. We have a really superb team. And in a very small percentage of patients, we call in our spinal surgery team for what's called a vertebral osteotomy. So this is patients that have a significant thoracic kyphosis where they're losing their horizon. And again, this requires really high-level surgical expertise because it's a big operation to take somebody from this posture to this posture, right? So we actually have a superb group of surgeons, but I would say of all our patients, it's only really 2 or 3 patients in a given year. It's very rarely for pain. It really has to do more with functioning in a vertical stance rather than Nish, you want to take it?
Okay. So we'll take another question. Please explain how ankylosing spondylitis and its inflammatory condition leads to heart disease. Whether AS patients should periodically be tested for narrowing of arteries and are followed by a cardiologist, and if so, at what stage? So it has been well recognized that inflammation can lead to accelerated atherosclerosis or clogging of arteries. And the exact mechanism is not known, but there is ample evidence to show that the process of formation of the cholesterol plaques or the plugs, which cause blockage, it is accelerated if there is inflammation in that same area. So probably that's the most likely explanation for this. Exactly how much, what percentage increase in risk has not been worked out well for AS, but for rheumatoid arthritis, which is probably much more studied in this regard, it's known that the risk for heart attacks and strokes is almost the same as that for diabetes. So it's not well known, but the risk is almost the same as the risk in diabetes mellitus. So it's very important to control inflammation because the obvious link is inflammation. So if we control inflammation, hopefully we can prevent the progression. At what stage should you be in touch with a cardiologist? I don't think you need to do that if there is no clinical evidence of cardiac involvement. But the more important thing is we should be aware that there is a risk. So we have to try to manage it and tackle it to prevent this from happening. One is with treatment and controlling inflammation, and at the same time managing other risk factors for cardiovascular disease, which can be weight, cigarette smoking, exercises, controlling your cholesterol levels, and we should be tackling it more at a much earlier stage and before it becomes clinically relevant.
Do you have a question there, Dr. Omar?
So there's a common question actually we always get asked in clinic. So it was to do with AS and diet. The questioner, can I mention your name? No? Somebody asked about diet and ankylosing spondylitis. So the question is, what are your opinions and perspectives regarding diet and gut health and autoimmune inflammatory disease? Should eliminating foods that create an inflammatory response in the body be an option, or managing disease via diet? So it's actually, Dr. Inman, even, I think you had discussed this in the ACR meeting as well, because it's such a fairly common question. So, I mean, there is no real, we don't have any kind of hard evidence yet, although anecdotally from our patients, some of our patients have participated in elimination diet, and a few I can actually remember swear by it. They feel that, so for example, eliminating starch, actually one patient that follows up with Dr. Haroon and also Dr. Inman, he has a few patients, I think, who believe in elimination diets. There is some published literature about the microbiome and how it actually interacts. So this is the gut flora or the gut bacteria, whether this has a role in the inflammatory process. There is some evidence to suggest that, but whether if you can manipulate certain bacteria in the bowel, could this actually lead to less of an inflammatory response, mainly Klebsiella? And one interesting study that actually I read was when they looked at native populations in North America who have a high penetrance of B27, HLA-B27 gene. When they looked at them, they looked at the prevalence of AS, and they found it to be, although they still had high penetrance of B27, they still have the same kind of prevalence of AS. But one subset of this group changed their diet, and suddenly their AS levels were pretty high. So there was maybe anecdotal evidence to suggest that diet can be a potential contributor to this issue, but we still don't have any hardline evidence. So certainly we don't have any kind of controlled studies to suggest certain elimination diets. We've often talked about it if we can somehow conduct a study, but it's actually possibly difficult to do. I don't know what Dr. Haroon and Dr. Inman think about this subject.
So it's an important question. We're actually very interested in what diet really does, because all we have so far is anecdotal evidence, but it's a very topical issue. There's one quick question here about research biologic treatment, such as Symphony and the other drugs during pregnancy. It's a short answer. Actually, we feel very confident about the safety of the biologics during pregnancy. So patients that, for example, have Crohn's disease or ankylosing spondylitis or even rheumatoid arthritis, the common practice now is to actually continue the biologic agent during the pregnancy. There is a small caveat when the first 6 months of the newborn's life, they ought not to have any live vaccines. That's an issue for the pediatrician. But as far as the safety of the Symphony or the Remicade, Humira during pregnancy, it looks very good. And in general, the other thing, one of our research fellows who's now back in Singapore, looked at patients before they're pregnant, women with AS in our clinic before and after pregnancy. And there was no evidence that the pregnancy itself changed or worsened the course of the AS, which is very reassuring. Laura?
Okay, so I have a question here. It says, a lot of exercise seems to aggravate my chest. What exercise should I avoid, and what type of exercise can I do to strengthen my chest muscles? So, two things here. So sometimes we have to learn how to balance how much exercise to do or how little exercise to do. So oftentimes, for most of us, I think we need to push ourselves hard in order to engage in regular exercise. But some people actually need to rein themselves back. So that's part of sort of experimenting with how much exercise you can actually engage in before you start to notice symptoms. And also, too, I think that when it comes to exercising when you're in a flare, obviously you need to not eliminate all exercise, but you have to modify how you do it. So, for example, stretching during a flare is, I think, very adequate, but again, you're just pushing it to the point where you start to feel that discomfort. And that may change from day to day in terms of how far that stretch goes. The other thing, too, is you may want to avoid, for example, if you're in a flare, the repetitive cardiovascular type of exercise that may make your flare worse. So you really need to temper and experiment in terms of how much and how intense you exercise depending on your symptoms. The other more specific question here is, what can I do to exercise my chest? So obviously, any type of stretching will help to improve some of the pain and symptoms, particularly if you have what we call kyphotic posture. But again, going back to the core strengthening exercises that are working both the abdominal muscles and the back muscles together simultaneously are really going to be your key in terms of helping strengthen both the back and your posture at the same time.
I have two quick questions on genetics. What if I don't have the B27 marker, is it still a genetic disease? And a related question is, are there other new genes implicated in this disease? So as Dr. Haroon said, about 80–85% of our patients have this particular gene. It's a normal gene in the 6 or 7% of the population. In addition to that, there are about 45 new genes that have been discovered through these international collaborative studies. But if you add the contributions of those other 44 genes are relatively very, very small. That bar graph that Dr. Haroon showed, but the big peak looks like the CN tower. That's really, B27 is the dominant genetic. But patients that are B27 negative have a course, with the exception perhaps of inflammation in the eye, that looks really much like the B27. So we think it's still a genetic disease, but it's not B27 driven. And some of the other gene markers that are implicated in the disease, for example, one's called the IL-23 receptor. It turns out there's a lot of interest in the pharmaceutical industry now about targeting IL-23 as another potential target. So sometimes the discoveries of new genes introduce new options for treatments.
So two questions on therapy, so I'll take them together. First question is, I have this illness for 8 years and I'm taking sulfasalazine tablets, but later changed to methotrexate injections, and I've been well for the past 3 months. What happens if I stop this medicine now? Second question is on TNF inhibitors. If you develop peripheral neuropathy on TNF inhibitors, what are the chances if I switch to another TNF inhibitor? So treatment of ankylosing spondylitis, once you go beyond anti-inflammatories or the diclofenac and Arthrotex and the Celebrex-like drugs, really so far, probably next year it will change, but so far the only option for controlling spinal symptoms, which is the back pain, the buttock pain and the neck pain, it has been only TNF inhibitors. Only those medications are able to control the spinal symptoms. Methotrexate and sulfasalazine are good for controlling inflammation in the peripheral joints, or if there is inflammation in the fingers or the places where the muscles get attached to the bones. So if you have more extra spinal, so peripheral knee swelling, ankle swelling, then you could try to control the inflammation there with sulfasalazine or methotrexate or other oral therapy. It is not really effective for spinal pain. There have been 3 or 4 different studies which have looked at this, and sulfasalazine has been found to have a little bit of effect in controlling pain, but really doesn't control the inflammation a great deal. So it is not recommended for spinal pain. Now, this patient might be using methotrexate or sulfasalazine for controlling peripheral arthritis. And if that is the case, unfortunately, as we were discussing before, there is no cure yet identified. And the general consensus is you have to be on these medications for many, many years together. The good thing about spondylitis is among the different rheumatic diseases, spondylitis is known to undergo remissions, which may be drug-induced or it may even go into remission without any treatment. So if you are in remission for a long period of time, the first thing which we can try and do is to decrease the frequency of taking the drug and decreasing the dose a little bit. If you tolerate that, then we can slowly taper off the dose rather than completely stopping. But this, I would think this is rare than common. So if you're really in remission, we could try to take you off these medications. And for the adverse effects with TNF inhibitors, generally for most adverse effects, including peripheral neuropathy, if you switch to another TNF inhibitor, unless it is because of inhibition of TNF. For example, if you have an infection, you cannot switch to another TNF inhibitor because the second TNF will also cause immunosuppression. But the peripheral neuropathy or the nerve involvement has been considered to be more drug-specific rather than TNF-specific. So a lot of people are able to tolerate if you switch to another TNF inhibitors. But I've had experience where you try 2 or 3, but you get a recurrence of the same. But a number of patients have been able to do it. And this is probably under-recognized, the peripheral neuropathy and the neurological symptoms. And we did an analysis of our patients, and approximately 10% of our patients have developed some form of neurological adverse effects. The most common is peripheral neuropathy, tingling and numbness. If you do a test, you may not be able to detect it. So it's not a major nerve involvement. It's a minor nerve which is not picked up by testing. And the second neurological most important thing would be headaches. A lot of people get headaches, with continued injections, they probably get over it, or if you switch, might have to switch rarely, then it's okay. Probably the most traumatic neurological involvement has been issues with memory and concentration, and I know Dr. Indan has one patient who got off the bus and completely forgot the way to her house. So that's rare, but it has happened, and that's something which has to be kept in mind.
There's a question here from one of the participants. Is exactly what would you expect from your rheumatology visit, such as any testing, blood work, or questionnaires, etc. So for those who haven't been to our clinic, one important thing is that when you come to the clinic, you'll have, rest assured, you'll have full support, and people will be there to explain the process. You will either, so obviously these clinics are led either by Dr. Rin or Dr. Haroon, and you definitely see one of the physicians depending on who you will see on that day. And then you'll see probably someone like me, a training clinical fellow, or maybe a medical resident. During the clinical encounter, there may be questionnaires that will be asked to fill, that you will fill in prior to the clinical encounter, or during as well, which is physician-led. If you're generous enough to join the research cohort, that questionnaire may be a little bit, it's actually a bit larger, so there's more extensive questioning, but it does help. Rest assured that these questionnaires will help our research, but some of it will actually help the clinical assessment as well, and it will assess how we make treatment decisions. And then in terms of after the treatment, depending on your clinical circumstance that day, we may ask for lab tests and we may ask for x-rays, depending on some of it. And sometimes we ask for other imaging modalities like MRIs, which will take time to actually arrange. But normally x-rays and lab work can actually be done on the same day. People who are running out of time, sometimes they can actually come back to the clinic within a few days to actually complete their testing. Okay.
Thank you. There's a couple of questions on triggering. We haven't really said much about cause, right? We really don't know the cause, but there are a couple of questions on triggering factors. So one is, AS has been around for a long time. There's actually some CT scans of Egyptian mummies that look like they have syndesmophytes. So we think that actually this disease has been around for many, many centuries, perhaps a millennia. Triggering factors. So one question had to do with stress. So this is a very common, and I'm glad Andrew just alluded to the one of the aspects of this disease that I think both physicians and nurses and physio sometimes we don't actually fully grasp is the emotional toll that this disease can take. And Andrew mentioned the depression. So this is a bit of a vicious cycle because stress and pain feed on each other. So if your back is flaring, you're more fatigued, you're more stressed, your tolerance for frustration is shorter, your temper's got a shorter fuse, and so it kind of cycles. And sometimes it's hard to know how to break into that cycle. Sometimes if we can shut off the inflammatory component, everything else, the emotional side, falls into place. But sometimes the emotional, psychological aspect of the disease really needs specific treatment and counseling. So it's a very important reminder. Infection was mentioned. There's interest not in the bacteria in the gut. We do have some examples of B27 individuals who travel abroad. They got an infection, say a salmonella infection. It triggered what we call reactive arthritis. And that group, actually, there's a subset that will go on over time to develop ankylosing spondylitis. So we have a strong suspicion that in some patients there is an infectious trigger, but it doesn't seem to be one that spans the whole group. The third triggering factor you'll read about, and we actually encounter, is the role of trauma. So this is somebody who's been, maybe you're rolling along with low-grade back pain in your 20s, and all of a sudden you're playing hockey and you hit the boards. Or you're at work and you fall off a ladder. And we feel the number of cases where that just seems to change the course of the back pain, where an injury, it can happen in a car accident too, seems to accelerate the severity of the arthritis. So we think that the HLA genes that Dr. Haroon mentioned are primarily there to respond to infection, but if there's inflammation from any source, like an injury to the back or the neck, that maybe having this genetic background kind of accelerates the inflammation. So it's an important question.
It was just to add, there was also a question whether whether season can affect.
Yeah, so seasonal effects, this applies to many rheumatic diseases, rheumatoid arthritis, fibromyalgia, ankylosing spondylitis. We'll find patients right about this time of year, the weather's getting damp, it's getting cold, my back is killing me. It seems to span most forms of arthritis. And we'd be happy to give you a slip to go to, Phoenix, Arizona for the winter, if that'll get you off work. But the fact is that ankylosing spondylitis occurs around the globe. So it occurs around the tropical climates. It occurs in northern Scandinavia. So it seems that in just about everywhere, where B27 occurs, you see a higher frequency, and that probably is a much bigger factor than the weather or the atmosphere.
Okay, I have a very short, simple question. Why are my calves so tight? So, well, obviously this could be related to posture, but the other thing that we haven't mentioned tonight, I don't think anybody's talked about, is enthesitis. So enthesitis is where you get localized inflammation where the tendons or ligaments insert into bones. So that could be, for example, plantar fasciitis, Achilles tendonitis, and this is related to the disease process itself. So that could be one cause of why your calves are tight. In terms of treatment for enthesitis, this is where we really look to sort of the combination of both pharmacological management and stretching and physiotherapy. So certainly anti-inflammatories, and in some cases the TNF inhibitors are quite effective in terms of helping alleviate the symptoms associated with enthesitis, but certainly gentle stretching as well is going to be important. Enthesitis can affect any areas, so it could be in the shoulders, the elbows, the heels, the knees. So it is important that you do, if you want to be stretching it, that you do stretch it appropriately. So seeking advice from a physiotherapist or kinesiologist who understands how the muscles insert and whatnot is going to be important.
Two related questions, in fact, the same question. The increase over the last 15 years in AS prevalence, what is the reason for that? Is it because of better education? Is it because of earlier diagnosis? Is the disease in fact increasing because of some environmental reason or something? So I think the major reason is increased awareness. First of all, there is an increased impetus for earlier diagnosis among doctors, physicians, because it is now recognized that it's probably a therapeutic window, a window of opportunity in treatment of ankylosing spondylitis. This is applicable for both for controlling inflammation as well as for controlling progression. So if you treat patients within the first 3 years, the chance of achieving a remission within 6 months is approximately 60%, as opposed to somebody who is diagnosed after 10 years, the chance of getting a 40% decrease in response is only around 50% by 6 months. So huge difference in the success rate of treatments depending on when the diagnosis was made and how early the treatment is started. The second reason is for progression. If you look at the rate of spinal fusion in patients who are diagnosed at less than 5 years and after 10 years, there's a big difference. So if you try to look at the rates less than 5 years, 5 to 10 years, and more than 10 years, the patients who got treatment after 10 years of disease, the rate of progression is almost the same as those who have never received TNF inhibitors. So probably the first 10 years is that window of opportunity for stopping progression, and maybe the first 3 to 5 years is the best chance of achieving a remission with treatment. So that's the importance, and because physicians are aware of this, there is more impetus to diagnose these patients early, and it's not like 20 years ago whether you have this disease or back pain, just take diclofenac or arthrotec. It's different now. There are options available to change your life completely. That's one of the most important reasons for that increase. And the advent of MRI scans, of course, has made a big difference. So it's now we're able to identify these patients at a much earlier stage than wait for X-rays. So some of the reasons for this increase.
Great. We're a little short of time, so a couple of last questions. One is, what's the deal with the biosimilars? Do they work? How much are they? I can tell you the biosimilars, they're coming in about 30% less than the brand name. That's so, for example, Inflectra versus Remicade. So it's a big issue for the insurance company or the Ontario government that might be funding these drugs. There are some head-to-head comparison studies coming out of mostly South Korea that compare infliximab with Inflectra. I think the medical community would like to see more data to reassure us that their efficacy and the safety is comparable, but I think it's coming. In the long run, it's going to drive costs down, which will benefit access for many of our patients, certainly around the world. One final question is, are there any double-blind studies that after taking a biologic can actually stop the medication safely? So there actually is a study going on now with a TNF inhibitor where all patients start, instead of being randomized to a placebo and the active drug at baseline, everybody gets the drug for 6 months. And those patients that are doing well are then randomized to a placebo or continued drug. So it's a very important question. We think that there are patients that actually can probably stop their biologics. They're actually inducing remission. At the moment, we don't have a good sense of how to identify those patients accurately, but I think it's certainly coming, which will be fabulous. That's the difference between a cure and a remission. Remission means you're under good control with the drug. Cure means you're great even though you've stopped the drug. And that's what our dream is, to find the cure. So if there are any, I'm aware of the clock, and if there are any additional questions, I'd like to thank our panelists who did a terrific job, and thank you all for coming. Feel free to come up and join us at the front here if there are questions that were not addressed in time. And I think Kathy McBay's got a small announcement.
I just want to thank Michael Mallinson for being our very long-term and very effective president for the Acadian chapter, and I want to know, are you taking memberships tonight, Michael? A lot of people have signed thank you cards for you. I'll leave them at the front in case you didn't get a chance to sign a thank you card, but we're very grateful for all your really effective advocacy for all of us and those who can't be here tonight. And so you can let us know if you're going to be taking any memberships from that little flyer. And also, Laura, is it good for my son who's at his computer all the time to be at a standing desk? Is that a good idea? And also, Dr. Inman, where do we go for the two people who have follow-up studies that you mentioned after the meeting?
They're coming. So we'll take those off. Thank you very much, Kathy, for recognizing. Michael, thank you very much for your leadership. Again, if you're interested in picking up an envelope from Daria about these clinical outcome measures, we're interested in measuring the impact of the disease on different aspects of life, and Casey Hemington's there too, studying the pain aspects. Thank you all for coming. It was great having your involvement.